It's my pleasure on behalf of Tilots Pharma to welcome you to this late evening session, so to speak, but nonetheless, we'll try to make it very instructive, very interactive. We have two wonderful speakers. We have a lot of case discussions. So we want you to contribute in several ways. You have a voting card, so I will ask questions, and if you disagree, it's going to be red, and if you agree, it's going to be white. Okay, that's quite simple. There's only two options. If you want to ask a question, you can either just yell, that's an option, you have microphones, or you can complete these cards. People will collect it and bring the cards to me. And is there an evaluation form, Robert, at the end of the symposium? In your folder, there's an evaluation form that we will collect at the exit, okay? So what we will do today is really focus on patients that you might see most, the patients with mild to moderate inflammatory bowel disease, which is the vast majority of our patients. And so we'll first start with the focus on ulcerative colitis, and the lecture on ulcerative colitis will be given by Professor Ailsa Hart from St. Mark's Hospital in London, where they see perhaps half of the UC patients in London. And Ailsa is very experienced in treating ulcerative colitis. The title of her talk is Success Factors in the Treatment of Mild to Moderate Ulcerative Colitis. Ailsa, please. There you go.
Thanks very much indeed, Gert, and welcome to everyone. It's a great pleasure being with you all this evening in Amsterdam. So what I thought we could cover in this talk is just to focus on the patient group that we're considering in this particular talk, and then just to make sure you're aware of how many of these patients you actually have in your practice. What's their disease likely to look like? How's the disease likely to behave over time? And then very much focus the talk on the factors that can make the difference to this group of patients. Factors around avoiding a delay in diagnosis, which is a very important issue, trying to get the right drug, the right dose, the right mode of delivery, the right time, and doing that every time. The patients have to be well informed. This is a very important part of IBD management to my mind. Appropriate monitoring and treatment escalation, and having a system of care which is going to work wherever you practice. So to start with some definitions, so when patients come into the clinic, they don't have mild, moderate or severe tattooed across their forehead. We have to sort of define what we're meaning about the severity of disease. And while I think it's very clear, the severe group, these are the patients who are going maybe over 6 times a day, and they've got systemic problems, maybe a mild fever or a tachycardia. We're clear on that group. I think it's maybe less clear, the distinction between mild and moderate. But we intuitively take all of these factors into account, not least the longitudinal, how the disease is progressing over time, as well as this cross-sectional moment to really evaluate whether the patient is mild, moderate, or severe. So there are various different ways to score it, and the Mayo Score is one of those ways. And of course, this takes into account stool frequency, whether there's blood in the stool, the endoscopic activity, and the physician's global assessment. And by amalgamating this score, that defines the disease severity. And just to give some examples of what these different Mayo scores look like, so this is a Mayo 0 with a completely normal mucosa, it looks shiny and smooth, with a Mayo 1 where you begin to get this decreased vascular pattern with some erythema, maybe some mild friability, and moving on to Mayo 2 with a much more marked erythema friability, absent vascular pattern and erosions, and then in Mayo 3, the very unpleasant looking sort of spontaneous bleeding with ulceration. This is one way of looking. Of course, there is also the UC-EIS now, and I think probably that's the direction we're going to be moving to really classify endoscopically these patients. And I think there is actually an unmet need in all of our endoscopy departments to increase the quality of our reporting and how we report the endoscopies on these patients. Of course, we also consider the extent of the disease, whether it is just a proctitis, whether it's a left-sided disease or a total colitis, because this influences the modality, how we actually administer the medical therapies, particularly with regards to 5-ASA. And really importantly, to consider the impact on that patient's life. So this is a nice study from Chicago from David Rubin, and whatever factor was looked at, whether life was just more stressful or difficult to lead a normal life or embarrassing or their disease wrecking an important moment, I'm afraid we as the clinicians persistently and consistently underestimate the effect of UC on patients' lives. So really important point to be aware of when we're in the clinic with patients. And just to make the point that Gert made to you, we're talking about the majority of our patients here. When you think of patients, whether it's patients reporting their classification, physicians or nurses, about 85% of patients are in this mild to moderate group. But of course, when we first meet our patients, we don't know how their disease is going to behave over time. We can't look into a crystal ball and judge whether someone is going to have a really difficult course of disease or, on the other hand, someone a more benign course of disease. Because, of course, some patients have a very unpleasant thing initially, but then their disease is very well behaved. For others, like in the bottom two graphs, they get into this grumbling, chronic, active, relapsing, remitting phase. But it's very difficult initially to tell what's going on. And it's only sometimes when you watch the disease and its behavior over time to really understand what it's up to. But are there any predictors? Are there any factors, clinical or otherwise, that really help us to decide how disease is going to behave? And I think for me it's the three factors in the purple at the bottom which predict disease outcomes which are likely to be less good in ulcerative colitis. So one is endoscopic lesions. It's what the disease is looking like under the endoscope, and I've shown you some of those pictures already. Another factor is extensive disease at diagnosis. So patients with a proctitis, much more likely to have an okay course of disease compared with those with an extensive or a complete colitis. But the group at the bottom is also a very important group to think about, and these are the patients who extend their disease fairly rapidly over time. So maybe they start off with a proctitis, but a few months later, the disease has started moving around the colon and they've extended their disease. Another poor prognostic factor in this group of patients. Because I think the art of all of this is actually trying to get the right balance, because we don't want to be under-treating difficult disease, and yet we don't want to be over-treating minimal disease. So I think part of the art of treating inflammatory bowel disease is trying to get this balance right. So what are the goals of treatment? Well, I think the ultimate goal is that the patients are well. And that means at the clinical level, that means they're coming into the clinic saying they're feeling better, but also we're raising the bar with what we're trying to achieve now. It's actually not good enough that they are just feeling better. We also want their bowels to be a better looking bowel, so endoscopically healed, and maybe raising the bar further still. And those of you who are in the symposium and the meeting this morning would have heard about the importance of histological healing, potentially with ulcerative colitis. Of course, in a chronic relapsing remitting disease, often starting in young age, in children, when they've got 6 decades of the disease in front of them, these patients have got to be robust psychologically as well, and all of this has got to be balanced without the side effects of therapies. Just to think of these goals in a slightly different way, so decreased symptoms, of course, but steroid-free remission is a very important goal. So it is no good still, and we've all got these patients in our clinics where they are well but on steroids. And I think it's up to us to challenge with the patient that that is not good enough. They need to be well and off steroids. We need to find modalities to actually achieve that goal. We've mentioned mucosal healing and the importance of no cancer. Still for patients, operations and a stoma, even a temporary stoma, is the biggest fear that comes out in most patient surveys. And right at the top, because I think it is the most important thing, is increased quality of life for patients. Just a case to think about. So this is an 18-year-old male who'd had a 2-month history of fecal urgency, some bleeding, and some cramps before he needed to go to the toilet. Stool tests were fine. There was no evidence of infection at all. On his bloods, there was a slight anemia. It was iron deficient, and this is what the bowel looked like. So it was about 15 to 17 centimeters only of disease looking like this, and the histology was consistent with an ulcerative proctitis. So now a question for you, and you can have your cards ready. So remember the red and the white card. So what are you going to do? Are you going to give rectal, that's the red card, or oral with the white card?
Okay, raise the cards. Okay, we're in a very communist environment. It's almost all red. Yeah.
It's all red. And what about the next thing? Would you be thinking about a mesalazine suppository with your red card, or a steroid enema or foam with the white card? We're still in the same place, aren't we?
Yeah, well, we agree. Well, basically, I'm not sure I agree. I was wondering, I mean, so this was not pure proctitis, it was 20 centimeters, is what you were saying, right?
Yeah, about 15 centimeters of disease.
Okay, I was considering, given the endoscopic appearance, should we not consider combined treatment? Thinking about your risk of extension, and can we prevent that by doing the combination of oral and topical? What's your thought on that? Or perhaps you're giving the answer.
So I think that's a very reasonable thought, that this is clearly quite severe looking disease endoscopically. This is just to remind you about the ECCO statement, which is very clear, and I think probably tallies with how you're voting, that coming in with a topical, for example, a 1 gram suppository initially once daily, is the preferred treatment for an active proctitis. Foam enemas are an alternative. Suppositories are likely to deliver the drug more effectively to the rectum and are better tolerated than enemas. Combining the topical with oral, which is what Gert was alluding to, or topical steroids, is more effective than either alone if you're wanting to escalate, or if you've got the sense that the disease is very much going in that direction. Just another case just to think about. So this is a 30-year-old woman this time with left-sided colitis for 5 years. She's on a dose of 2.4 grams of oral 5-ASA and is complying with that, and she's taking some topical 5-ASA very much on an as-required basis. She's had a previous course of prednisolone, which she hated. She really didn't like the spots and the side effects she got from that. And then she comes back from a holiday in the Mediterranean with a flare. So she's going about 5 or 6 times a day now with a bit of blood, a mildly raised fecal calprotectin and CRP. So what are you thinking about here? Are you going to just increase her 5-ASA, and she's still taking her topical, but maybe encourage her to optimize that? Or are you going to think about maybe some of these different steroids like oral beclomethasone, dipropionate, or budesonide MMX?
Let's take the votes. Still pretty red here.
Pretty red, but with a bit of white there now.
Yeah.
So again...
10% white, more or less.
10% white. So again, the ECCO statements, I think, are quite clear on this, that for left-sided disease, exactly as this young woman had, initially treated with an aminosalicylate enema, combined with oral mesalazine, topical therapy with steroids or aminosalicylates alone, as well as monotherapy with oral aminosalicylates are less effective than oral plus. Topical mesalazine is more effective than topical steroids, so in head-to-head trials, topical mesalazine wins, and once daily dosing is okay. But you can come in with corticosteroids as appropriate if you need to thereafter.
So what did you do in this patient?
So with this patient, I optimised her 5-ASA, but I think the key thing here is to keep a very close eye, because if you're not winning with that strategy,
suppose
you're going to
she
move
responds, what would be your maintenance recommendation? She responds to your 4.8 and your daily enemas. What will you do after?
So I would probably, as maintenance, de-escalator and still encourage a bit of the topical use. I think a lot of the topical side of things is all to do with having an engaged patient who sees these topical therapies not as their difficult things to make life worse for them, but they're allies that live in the cupboard. They can forget about them at weekends, but they use them in a way to try and optimize disease control. And I think that's all to do with having a well-engaged patient who really understands the benefit of that sort of approach.
Yeah, there's not much data. I think there's only one study about maintenance combination treatment, but it was clearly superior in an Italian study. And there are definitely patients that you can keep off steroids by just having them comply with a couple of enemas per week.
Yep.
I have patients every other day, every third day, sometimes even once a week, plus the oral. And that keeps them off the steroids.
And I think that's very important for the proctitis patients in particular, because they're the ones who can maybe stop everything. But some form of maintenance therapy, I think, is important, and for them to understand that it is a chronic relapsing remitting disease, and with nothing the disease is likely to come back through. So maybe let's think now a little bit about some of these factors that can maybe really make the difference in this group of patients. So the importance of early diagnosis, and we still do have a problem of a delay in diagnosis in children and adults, and actually it's a median of 4 months for colitis. It's longer for Crohn's. I think patients who've got bleeding per rectum at least are beginning to think there is some problem and will seek advice. But nonetheless, we do have a problem on our hands, and I think it's up to all of us to think about ways that we can optimize this. One might be just the increased awareness of IBD, and that's an overarching thing, but also education at the level of primary care, but also sometimes these patients come through other specialties, so it's educating our colleagues as well as primary care physicians about this, and systems to make sure that you can get patients very quickly onto the right therapies. What about the right drug and the right dose, the right delivery? So, of course, there are lots of different ways we can give 5-ASA drugs, from the rectal systems, enemas and suppositories, to pH and sustained release, controlled release, delayed release, and some of these prodrugs. But again, what I would encourage you, if you haven't already done this, is to make sure you are familiar with what these systems look like. What do these different enemas look like? What are the suppositories like? What do some of these capsules really look like? Because some of these are very big capsules. I call them horse tablets, some of these tablets, and they need to be taken a lot, several times a day. Same with enemas and suppositories, different volumes, different ways of releasing them, and make sure that you have at least seen some of these preparations, that when we are counselling patients, we know exactly what we're saying about these different modes of delivery. So how do we optimize these drugs? Well, I think it's trying to get all of these three factors right, get the right dose and optimize that. Combine oral with rectal as necessary, and this I think is a really important point. And sometimes you just need to bash on with a 5-ASA drug, as long as you've got a really clear system of care that you can monitor carefully, and if they're not doing well, you can optimize and escalate their therapy as necessary. So this is the data which you're all familiar with from the ASCEND-2 study, clearly showing that the 4.8 gram dose is better than the 2.4 gram dose when needed. And this is the data showing that combination of oral and rectal 5-ASA versus oral alone is better in pancolitis. So the purple bars, whether you look at 4 weeks or 8 weeks, is superior to the monotherapy alone. And although I think we might think we're good at doing this, I think the data maybe doesn't support that we're quite as good at doing this as we think we are. So this is data from 800 IBD patients in the Swiss IBD cohort. Only actually about 40% of patients with proctitis are on topical treatment, and a really low number, about 10%, with pancolitis were. So I think although we know that data, sometimes we're maybe not good enough at explaining to patients that this double-pronged attack of oral and topical is superior to just oral alone. And again, sometimes patients don't see the benefit when it goes all the way round the bowel. But if that patient has got urgency as a symptom, then I think that can help to engage the patient that, if you like, marinating that sore bit of rectum in the right thing is going to be a way to improve particularly that symptom of urgency. What about just extending the duration? Well, this is the data from Mike Ham's trial. Patients who failed to achieve remission after 8 weeks were extended for a further 8 weeks, and indeed patients did do better with extended therapy. But please, with a caveat, not just to leave those patients alone. They do need careful monitoring, a way to get into, for example, the IBD nurse helpline if they're not managing, so that you can escalate therapy as necessary. What about this point that Gert was making about where exactly we're getting enemas and suppositories? Well, enemas may not provide good delivery just to the rectum. This is some nice data in about 30 patients with UC, in which scintigraphy was done after administration of enemas of different volumes, so a 30, 60 and 100 ml volume. And actually, as you can see, the rectum, which is the dark pink here, very little was actually in the rectum. So sometimes it might be that adding an enema and a suppository, using that double approach, can be helpful to really try and get the drug to the right place. But I think binding together all of those ways of optimizing 5-ASA is adherence. And for me, these drugs are fantastic drugs for ulcerative colitis, but only if the patient takes them, and only if they take them consistently. So we know we've got a problem on our hands. This is the WHO report on non-adherence. So around or up to 50% of medicines prescribed for long-term illnesses are not taken as directed. And certainly from the IBD literature, we know that it is poor. Even in clinical trials, it's not 100%. But if you look at community-based trials, it's lower, between 40 and 60%, and probably even lower still in real life. And we know that this sort of non-adherence results in a significant, about 5-fold increase in the risk of relapse, and also that lower overall medical costs will happen if we get adherent patients. So the importance of adherence, I cannot really underline enough. What about the strategies to help with this? Well, Once a day versus conventional dosing, and this is data showing certainly at 3 months that once a day does help compliance more than twice a day or 3 times a day. But actually that benefit is lost if you push it out to 6 months. And certainly my feeling is if a patient has formed a habit on a twice daily dose, I wouldn't particularly advocate breaking that habit for them, because I think a lot of this is to do with habit-forming practice. What are the other predictors of non-adherence? Well, I always find it quite startling that about 70% of non-compliance is intentional. That means that patients know what they're meant to be doing, they're just choosing not to do it. And even though we might think some of these factors like gender or income or various factors are pushing them in the direction of non-compliance, actually the stronger evidence comes about beliefs about illness, the necessity or the perceived need for that treatment, perceived effect of that drug, worries about the drug, and indeed a lot of these patients do have problems with depression and other psychological morbidity. So how can we address this? Well, I think everyone in this room can help with this in educating and motivating our patients. And I have to say I'm particularly interested in a technique called motivational interviewing, which is a way, it's actually from psychotherapy, trying to help patients with alcohol problems or drug abuse to change their behavior. And in chronic disease, taking a tablet is not that dissimilar from just changing a behavioral thing. So educating about the disease and the benefits of maintaining remission. If a patient can see what's in it for them to take a therapy, that will help. And integrate that into the patient's life. Make it work for the patient. These things like the enemas or suppositories, they are the patient's allies. They're to make the patient's life better, not worse. Treat depression, and I think it's very much undertreated actually, and make it convenient for them. So obviously if patients are struggling with multiple pills, multiple times a day, do make it easier for them. Finally, what about the system of care? Well, all of our clinics are busy, and I think capacity is a really big problem that we're all facing now in our different clinics. Of course, there's the benefit of the face-to-face interview, but there's also a great benefit of some telephone consults and the IBD nurses doing some more remote ways of assessing patients on phone lines or indeed email as well. In the UK, we've just started using this particular bit of software called Patient Knows Best, and it is exactly what it says on the ticket here. The patient is very much in charge of their own records and will interact through this particular website and feedback about symptoms. And actually interdigitating this form of patient empowerment with some form of virtual monitoring through a virtual clinic or a telephone helpline can be a very powerful way of trying to run these patients through the clinics. Finally, just another very important point, not all symptoms are due to inflammation. So some of the really big issues for patients might not be due to inflammation. Fatigue, pain, urgency can be problems even for patients when they are in remission. So always be careful in these consultations to clarify exactly what symptoms are a priority for that patient. We are really bad at asking about urgency and incontinence. It's a big problem for patients. Up to 2/3 report that it's a problem for them, even in remission. Patients don't report and we don't ask. It's a taboo subject, but please do consider this and do ask the patients. Just be careful to think, are there any other causes of their symptoms, of which there are many, bile salt malabsorption being one. So follow a clear algorithm for investigating the non-inflammatory causes to make sure you're optimizing everything and use all the tools we've got in the toolbox. Thinking about their diet. Patients always want to know about their diet. Make sure you've got an IBD dietitian within your clinic to really help with that and counsel patients. Use Imodium judiciously but well. It's an excellent drug to help with this, antidepressants, and please do be very cognizant of psychological therapy for these patients. So in summary, seek ways to avoid delays in diagnosis, raising the bar, goals to achieve in IBD. If we increase our expectations about what we can achieve for these patients, it'll increase the patient's expectations. Try and get the right drug, the right dose, the right mode of delivery, the right time, and try and get that every time. For me, the heart of IBD is assessing and monitoring disease. Patients who fall out of the system, they're the ones who can get into real trouble. So an engaged patient who is going to be carefully assessed and monitored throughout time. Develop models of care, of which there are many that are going to fit your service. Always respect patient preference. They've got their own issues which they're bring into the clinic to make sure that you've got a balanced decision being made for that individual patient and motivate your patients. And just be aware that all symptoms are not due to inflammation, but they are still really important symptoms that for the patient and need addressing. Thanks very much indeed.
You know, we have so many different mesalazines now that we can choose from what to prescribe. What would be your guidance and what would be the single best improvement of mesalazine for the clinic and for the compliance issue, you know?
So my own opinion here is that I don't have a particular preference for a 5-ASA drug, but what I do have a very strong feeling about is getting the right dose given by the right way in someone who knows what they're doing with it. I think it's far too easy to prescribe something, not really knowing what you're prescribing some of the time, or not knowing to tell the patient how to give an enema, how to give a suppository. Now, our nursing colleagues are excellent at this, but we need to be as excellent in really counselling these patients about what they're doing. So it's not that I have a preferred one over another. I think it's all to do actually with how we talk to the patients about these drugs.
But you go with a single dose in the morning, probably?
If I was starting, I would go with a single dose. If a patient is established on a drug, which is a BD or whatever, and that just works for them, I wouldn't switch it.
Okay. There's a question, please.
Sorry, I'm from Macclesfield. You stressed the importance of assess, monitor. I wanted to ask, do you use calprotectin? Because we are increasingly using that. Actually, it helps us a lot, actually, because when patients have symptoms, we check them and they're negative, actually, so we then look at alternative diagnosis. But do you have a protocol incorporated to do this on a routine basis? Because that helps us in a lot of things, because where the patient is not taking the drugs, they can have a flare-up, and that can indirectly give us more information, actually. So that, is that something you use routinely? Or?
No, I think a very important point, and I think it's part of the assessments. The jigsaw puzzle has got to include, obviously, the symptoms, the objective markers, calprotectin or CRP, and if they need something further, an endoscopy, but the whole jigsaw puzzle to try and map what's going on over time. And you know, the old model used to be these patients would come into clinic and they'd be seen. But a lot of these models of care now in the UK, we are actually trying to do some of this a bit more remotely for this group of patients who are the milder end of the spectrum. So the patients, for example, on that patient knows best, they can feed in their symptoms, and then they can go to their GP at a certain time interval and have their calprotectin assessed, get the data back, and then they are guided through that, how to escalate their therapies.
Yeah, I mean, when they have symptoms, we are advising them to have their calpro checked, actually, and then so that gives us feedback, and then we can advise them accordingly, actually. So maybe that's something we need to incorporate in routine practice.
And I think it helps to give the patients feedback as well, because I think it can be difficult for the patients to know if their wobbly symptoms are really needing dose escalation, or actually whether they are other causes of their symptoms to wobble, in which case that's not the right approach.
So perhaps a question also to Peter. In your practice, Peter, do you dose escalate or de-escalate based on what the patients tell you, or would you prefer to scope them? How do you do that in your practice?
Whenever we dose escalate, I would try to motivate the patient to get an assessment. So we talk with the patient, and then we do a reassessment, and then we de-escalate treatments.
But how does it work in your clinic when the patient is in front of you, is telling me I have a bit more symptoms? Can you do that endoscopy like right away, or does the patient need to come back?
Most of the time we can do it right away.
Okay, and then you decide. So that's how it usually goes. Ailsa, how you're doing it in London?
So I think it depends on a bit the individual situation, but if the data would have to stack up. So if there's something objective as well, that would be the prompt to de-escalate.
Sure, please.
I'm Babar Javed. I'm a gastroenterologist in Bedford, UK. In UK, we have got quite patchy and difficult access to psychological services. So you mentioned depression, and we do, I feel that quite often you think this patient does look quite down, and often your own impression is that probably there's an element of depression here. But in terms of actually initiating antidepressant therapy or having access to services where that can be done more properly than myself, what's your view on that, from UK perspective?
Yeah, so I mean, I'd feel anxious about initiating antidepressants in the younger patients, particularly the adolescent patients, and this is a big issue in that particular group, just because of some of the data on suicide and so on with various classes of antidepressants. I think that does need a more specialist approach, but actually in adults, I do prescribe quite a lot of antidepressants to these patients, or work closely with the GPs to enable that. And I think it's something that we probably underdo on the whole, actually.
Perhaps a last question for you, Ailsa, here coming from the room. In patients that do well, how easily do you dose de-escalate? Do you think there's like a one size fits all for maintenance treatment, or do you look at it more at an individual basis? How do you titrate it, the dose?
What do you mean by one size fits all, exactly?
One dose that is the best maintenance dose for all the UC patients?
I mean, I think about the 2 gram-ish mark is okay.
So 2 gram-ish is okay, but you don't believe that certain patients need more for their maintenance than others, or what is your view on that?
I think, again, it depends on what the disease has done up until any moment in time. I think the history for an individual patient can paint the picture for their henceforward. And that's where we often, we're trying to group patients. But when you've got someone in front of you, the history up until that moment in time, for me, dictates the henceforward management a lot. Okay. So they've had a lot of trouble. I wouldn't de-escalate back down to a low dose. I would keep them on a higher dose. However, if you think, do you know what, they've only had the odd little problem, right, let's try this lower dose.
Yeah, I think that's the message I wanted to hear, that really if patients need a higher dose, you probably just should continue the high dose. Peter, is that, how do you find the right dose for the right patient?
I think, well, it depends. Not all patients receive the same maintenance dose, so that's true.
Okay. Now, thank you very much. It was a very elegant lecture and discussion.